at risk. Thank you for spending part of your Sunday afternoon with us on this extremely timely topic. My name is Jan Lance, and I will be your moderator today. I am a retired public school teacher and current president of the Austin chapter of Texas Alliance for Retired Americans. I've been following healthcare policy and issues closely since 2017, and I am honored to be at the table today with these experts in the field. I will, before I introduce them briefly, I will tell you that Representative Donna Howard will not be here today. She had to cancel, but I don't think you're going to be disappointed. We have a wonderful panel. So I'll introduce them briefly now and then more in depth later. First, to my left, Lynn Cowles is Director of Health and Food Justice at Every Texan. Then next to her is Dr. Karen Smith, Family Physician at Baylor, Scott & White in Manor. And then at the end of the table is Dr. Christine Eady Mann, Board Certified Family Medicine Physician. So thank you all for being here. I also want to thank the sponsors for this event. Live Oak Unitarian Universalist Church, thank you so much for sharing this wonderful facility. Indivisible 1431, thank you for the planning and preparation you have put into this event. It's not as easy as it looks to put something up like this. My organization, Texas Alliance for Retired Americans, advocates for retiree issues. And as you can imagine, protecting health care right now, and for us that's Medicare and Medicaid, is a big part of our advocacy work. Our Terra motto is, let's not be the last generation to retire. And to that end, thank you. We are very serious about that. And to that end, we support quality, affordable health care at all stages of life. In my capacity as an advocate for retiree issues, I'm going to take the prerogative to start today by highlighting two particular issues that many perceive as grave threats to Medicare beneficiaries and providers. We may have time to address them a little bit more later, but I just wanted to give you a broad outline to start out. First, the tax and spending bill, H.R. 1, signed by President Trump on July 4th, increases the nation's deficit by over $3 trillion. Under the pay-as-you-go budget law, this increased budget deficit will trigger automatic spending cuts to offset the deficit. Medicare payments are subject to these cuts. Across the board, Medicare cuts will amount to around $500 billion over 10 years and affect all beneficiaries and every healthcare provider that accepts Medicare. Now, these budget cuts can be avoided if Congress votes to exempt Medicare from the pay-as-you-go cuts. That's happened in the past under similar circumstances, and there's a bill right now before Congress to pass that waiver. However, since July, current leadership has chosen not to vote on this exemption, so we are watching and waiting to see what happens there. The second thing I'd like to tell you about is the Trump administration, through Centers for Medicare and Medicaid Services, is launching a pilot program called WISER. And that name is kind of a convoluted thing. It will require prior authorization on certain health services in traditional Medicare. It's based on the premise that it will address fraud, waste, and abuse. The pilot will begin in January 2026 in 6 states, and Texas is one of those states. According to that pilot program, prior authorization will be required for many Medicare services. Prior authorization is common in Medicare Advantage and regular insurance, but has rarely been used in traditional Medicare. Healthcare providers will need to obtain approval from for-profit companies who will use artificial intelligence technology to determine whether Medicare patients should be covered for certain medical procedures. Furthermore, the contracted AI companies will have a strong financial incentive to deny claims, as they will be paid for any savings generated from rejections. Now, no one is opposed to stopping fraud, waste, and abuse. We would like to see it done on a little more systematic basis where it's actually identified before it's eliminated, but we are mainly concerned that denying claims to save money will be done at the expense of senior citizens' health care. So that is being, like I said, that is not controlled by Congress. That is just a pilot program through the CMS that we have very little control over. There are some groups who are organizing to at least raise the alarm, which is kind of what I'm doing here today. If you would like more information, there are some fact sheets from Tara out on the table just outside the door, or you can go to retiredamericans.org. So now, what you really came here today for. So here's how the panel is going to work. Each panelist will give a short presentation on assigned topics of interest. Following all of the panelists' presentations, there will be opportunity for audience questions. You're going to hear a lot of information today from three panelists who are authorities in the healthcare field. I suggest that you listen, that as you listen, you consider this question. Is American healthcare at risk under the Trump administration? You can draw your own conclusions. The facts will speak for themselves. So, first, I'm going to introduce Lynn Cowles. Lynn is Director of Health and Food Justice at Every Texan, where she works to increase food security and access to affordable health care coverage for all Texans, regardless of income, immigration status, employment status, education, primary speaking language, gender identity, or medical history. She is a community health worker and a subject matter expert on the Affordable Care Act, Texas health programs and policies, health education, and health communications. She received her PhD in humanities research at UT Austin in 2015 and joined Every Texan in June 2024. We've given her the easy, I think, task of explaining national and state health care policy.
Thank you.
Pass it to you.
Thanks for the luck, everybody. I'm so grateful for the opportunity to be here and to share with y'all and learn from y'all also. Thank you so much for that overview of the WISA program and also some of the pay-go cuts to Medicare, which of course the administration, like with Medicaid and like with food stamps, ensured Americans would not get touched by a federal budget bill, right? That the only things that these cuts would affect would be waste, fraud, and abuse, like Jan mentioned in the system. And the reality is, like many things connected to American healthcare, we don't study the things that we don't want to understand. And so we put our blinders on and we do the see no evil, hear no evil. Yeah. And I'm sure we'll talk a little bit about that kind of political and economic methodology today, just putting on our blinders. But with respect to some of our budget cuts, we don't understand waste, fraud, and abuse because we don't study it in this country. We don't study it in Texas. Also, there are many systems of spending that we don't fully understand across the state because they lack transparency, and that causes these real, I think, like complexities in understanding that prevent people like us in this room from being able to advocate for one policy or another due to the complexity of the ways that systems interact with one another, and also the ways that we can understand or specifically not understand them, right? So waste, fraud, and abuse, just to kind of like put this on the table, right? And I really appreciate our provider networks. I do appreciate the excellent work that comes from some of our insurance companies in Texas and around the country as well. We can talk about some of the really cool stuff that our insurance companies are doing, in addition to some of the really terrible things that are happening in our insurance companies, like with the prior authorization standards, right? But most waste, fraud, and abuse in healthcare systems comes from either insurance companies or providers, right? And again, like, no, this is not a negative comment on providers or provider networks in any way. This is just the reality of how millions to billions of dollars get siphoned out of our healthcare system. Yeah, hospitals too. Yeah, right. Not just, yeah. Thank you so much, Dr. Smith. Right. Yeah. And so we don't have really beneficiary fraud in Medicaid or in Medicare. It's hard enough to get into these systems. It's hard enough to use these systems. Nobody wants to fill out a 30-page Medicaid application in order to go see a primary care doctor, to get a prior authorization, to see it, the systems are already too convoluted. So I like to start with that because there's so much misinformation right now out there about waste, fraud, and abuse being the sort of cornerstone for the purposes of these policies. And when we hear political leaders saying things like the only people who lose access to programs in these cuts, whether it be a legislative cut like HR 1, or whether it be an executive order that removes programs from certain people from access, those different policies, they affect people who are eligible for those programs anyways, right? So they don't remove eligibility from anybody who shouldn't have been. They just cut eligible people from those programs. But we can talk about how the administration right now is really like redefining some definitions for like who fits into what category, right? Like what it means to be eligible to be waived from a work requirement for the Supplemental Nutrition Assistance Program, or SNAP food stamps. And how the administration is just kind of like shifting definitions for who fits into those exempt categories. Because this is really important moving forward, people who used to be exempt from needing to meet work requirements for SNAP food stamps included veterans, people who were unhoused, and people who had children who were aged 14 years and older. Now all of those people have to meet work requirements for SNAP moving forward. And we all know that a work requirement is a cut, right? A work requirement is meant to create a paperwork burden for people so that they can't meet that paperwork burden, so then they get removed from a program, right? And so when we say, SNAP work requirements in Texas, what that means is SNAP cuts in Texas. And I will say also, I was in a meeting with the Health and Human Services Commission on Friday last week, and Texas does not have to operate SNAP. Right? There's no federal requirement, and I don't say this to be alarmist, right? But it's just like food is one of the main environmental sources of health that we have in, I was going to say in this state, but in this country in general, right? In terms of our human development, like much more of our health comes from the food that we eat than comes from what we experience in the doctor's office, right? It's one of those like non-medical drivers of health or social determinants of health that we talk about. And so people's access to food in Texas is extremely important in terms of their health care and in terms of our population health. But because HR 1, the bill that Jan mentioned, will transfer the administrative cost of running SNAP food stamps onto states, it will also, depending on some calculations and how accurate the state of Texas is in administering the actual SNAP dollars that get put onto people's Lone Star cards that then they use at the grocery store, right? Depending on our error rates in distributing those SNAP dollars, Texas could be required by the federal government to pay for up to 50% of all SNAP dollars doled out to beneficiaries, which would be $700 billion a year. Just like incredible amounts of money. And our state lawmakers will eventually be the ones who will make the decision, we can afford that or we can't afford that. And if they decide that we can't afford that, then that removes SNAP, the program, from the state of Texas, right? So there really are some dire consequences coming from HR 1 that are on the table right now. I'll go through a little bit more of just some of the specificities of that bill, but again, I'm really excited to hear from y'all in the Q&A about the things that your community members and your neighbors are concerned about. There's also, we'll have lots of opportunities to work with the state legislature moving forward. I left my card on the table outside also, so if anybody wants to grab that, reach out. What we're trying to do at Every Texan is create like healthcare voters, right? And organize systems of political influence around the state in terms of indivisible meetings with elected representatives in town halls to try to get the word out, right? Make sure that our lawmakers understand that we know what's happening and that we're organized enough to try to say we'll get 5,000 people to vote for you or not vote for you if you allow these cuts to go through. But yeah, so healthcare voters will be important moving forward, and I think a lot of people in this room, maybe being in a healthcare at risk panel on Sunday afternoon, might fit into that category. But there's lots of other kind of priority reasons to vote too, right? So just to back up a little bit from some of those kind of immediately urgent things that are happening in Texas right now, there's three sort of main policy solutions at the state level, combined between national and state level, that will really improve Texans' access to health care. And one of them at the state level is, of course, Medicaid expansion. Has everyone heard of Medicaid expansion in this room? Okay, good. So yeah, by closing the coverage gap, of course, we would cover, estimated, I would say estimated 5 million people in Texas right now who don't qualify for financial help to purchase insurance on the health insurance marketplace, and who also don't qualify for Medicaid because we don't have Medicaid for low-income adults in Texas. So this would open up that option for Texans up to the tune of probably 4 to 5 million people, and that would not only stabilize the healthcare system in Texas, not only of course give families and individual community members access to healthcare, but it would also allow us to draw down federal dollars for things like emergency Medicaid for populations of people who wouldn't qualify for any healthcare program in the United States, usually because of their immigration status. So there's all these sort of connections, right, between the programs that we fund and then also other federal funding sources or even state funding sources that we can draw down from when we opt into those programs. So Medicaid expansion is something that we will continue talking about at Every Texan, even though there is no political will for it in the state right now from our leadership, right? But among the population in Texas, there's incredible political will for Medicaid expansion. And we call it closing the coverage gap because Medicaid expansion has become such a hot button term in the Texas State House. So you'll see, if you end up following us on social media over the course of 2026, we've got a campaign coming out that really tries to envision what Texas will look like when the state has closed the coverage gap. How much more money we'll have floating through, or really funding and financing our healthcare delivery systems in the state, which is billions of dollars, right? Billions with a B of dollars. But then drop medication costs for people, that drop primary care healthcare costs, and that drop healthcare costs also for people who are uninsured, because we will still have some uninsured people in the state, right? And then also we have policies that haven't gotten any movement, honestly, in the Texas State House in the last few legislative sessions are ones that streamline eligibility and enrollment into Medicaid for young people. In Texas, we generally have Medicaid for people who are under 19 years old, for people who have disabilities, or for people who are pregnant. And by streamlining some of the eligibility rules, it means if a pregnant person gives birth to a child in a hospital, then that child automatically gets enrolled in Medicaid. That's a streamlining process, right? Because nobody needs to fill out an application for that child, even though they don't have a social security number yet, right? There's other things that we can do in Texas that would automate data retrieval from federal information hubs that would allow people's Medicaid applications to get sort of automatically accepted or provisionally accepted while the state was confirming data from different data sources. This happens at credit bureaus around the country. It happens in employment offices around the country. There's many industries that use these types of verified data sources, but the Health and Human Services Commission in Texas just doesn't have the legislative direction to do that in this state. So we make people fill out paper applications. We make them send in 15-page packets of paper that say, this is my address, this is my income, And then people forget sometimes to supply a second packet, and we just end up with, millions of uninsured kids. I'm sure a lot of people saw the census data that came out a couple weeks ago, showing that Texas still has the highest rates of uninsured adults in the country, but also the highest rates of uninsured kids. So this creates it's a culture of a lack of access, and people don't grow up knowing to go see the primary care doctor for, an annual physical, or to go get a cold checked out before it turns into a pneumonia infection, right? And so things just get more expensive down the road because we don't establish the culture of coverage when people are young, or for families. And then at the national level, and this is not there's not political will for this either right now, but there are researchers, of course, who are consistently writing about and consistently devising ways for us to really save money in the American healthcare system and to provide equal access to care. I mean, at a very basic level of care by operating a national health plan, right? And some type of national health program, thank you, that would cover everybody. And the research is out there, science is out there about the community health benefits that come when we have a nationalized health plan. And there, of course, will be moments in our history in the next 20 to 30 years as we negotiate the necessity for this type of health plan, as far as who can be enrolled and who can keep their employer plan as a supplemental plan. But the point is that we have this incredibly obtuse and hard to navigate system in the United States that comes from our 70-year history of developing healthcare programs for certain people based on all those different qualifications that Jan mentioned in my bio, right? Like what your income is, what your age is, where you are, what conditions you have, are you pregnant, do you have end-stage renal disease, right? Like what's your immigration status, what's your employer's, all of these things are the really complex pieces of information that go into what types of healthcare plans somebody can be in. And so what it does is we put a Band-Aid on a Band-Aid on a Band-Aid on a Band-Aid, and it fall through the cracks, right? And so in order to create an equitable, again, healthcare system in the United States that is not based on all of those different components of uncertainty, you create a stable market, whether it's like a Medicare Advantage for all or a Medicaid for all, and we can talk about the differences of what those kind of different financing models will look like. But regardless, you create the security, the financial and healthcare security for people by saying there's a basic program for everyone, doesn't matter who your employer is, right? And so that's what we're also working for, not only at every Texan, but with our network of national partners to really try to make sure that conversation keeps going, even though we don't have the political will for it right now. So I'm really happy to join with y'all and continue arguing for and explaining the necessity of these types of programs as we move forward, to avoid the pitfalls of bills like HR 1, policies like CMS's. The second thing that's really damaging our future of coverage in Texas and around the United States is these marketplace integrity and affordability rules that came out that got finalized in June. And then last thing is the expiration of enhanced advance premium tax credits, which are the financial help that the U.S. Treasury sends to people's health insurance companies to help them purchase private health insurance through the Affordable Care Act's health insurance marketplace. So this is Obamacare, basically, right? Like Obamacare provides subsidies to help people purchase health insurance. And the Biden administration increased those subsidies and made health insurance more affordable than ever before. And we saw health insurance enrollment in Texas double since 2021, since the implementation of these extra subsidies. And so the likelihood right now is that we will see that number probably not drop 100% back down to 1.9 million covered people through the ACA in Texas, but probably drop by maybe 1 million, maybe 1.5 million. Some estimates are more conservative. I'm not as conservative in those estimates because I've seen directly how those increased subsidies really increase affordability for people. And so the expiration of those tax credits is on the table right now and is honestly one of the purported causes of the government shutdown. Because political leaders are saying if we extend these tax credits, then they'll go to people who don't have immigration status in the United States to actually deserve them. None of that is true. There's 100% is never possible, right? Because statistically it's not possible, but nobody is enrolled in the Affordable Care Act who is not a legally permanent or a lawfully present resident in the United States, is to some degree, right? And then of course HR1, and I'll wrap it up here. HR1 changes who is eligible for those subsidies in 2027. HR1 also cuts off Medicaid to immigrant populations across the country in 2026, right? So we'll just see like the numbers of uninsured people, if these policies maintain themselves through 2026, through 2027, we will only see more uninsured people in Texas. We will only see higher healthcare costs. And I know Dr. Mann is going to get into some of these consequences of the bills that I'm sort of like piecing my way through here. But the thing is, we can change this at the midterms, right? There can be a big wave. We can get down into the valley. We can flip those districts to flip during the 2024 election and show leaders in Congress what our priorities are. And if we do have a different makeup in our legislative and executive branch, it would be the legislative branch at that point. But any kind of roadblock here for the executive administration right now would be remarkably helpful at undoing executive orders like those that declare the end of birthright citizenship, which also affects healthcare, because it affects who can get into Medicaid, whether or not you're a citizen when you're born in the United States or in Texas, right? So that is to say, there is a huge opportunity coming up, not this election right in November, but in the coming election. So we'll do more of this together, for sure. We'll make sure that we understand our power as healthcare voters and voters in general, and really to reach out to the people who in our communities, at this point, probably haven't had the clearest understanding of the fact that the people who are in Washington, D.C. make decisions about the money that funds our healthcare programs, but those are the connections that we need to make so that people who are on Medicaid using the Affordable Care Act understand that the decisions that they make or don't make at the ballot box drastically affect their healthcare here in the state and in the country. So thank you so much for being here again. I'm so happy to share the space with you, and very excited to pass this mic over to Dr. Smith.
Okay. We may bounce around a little bit now because our topics really intersect. This whole thing is like a spider web. No, spider webs are more organized. Never mind. Okay.
We're organized.
We are. I'm talking about Dr. Karen Smith is a family physician at Baylor Scott & White in Manor and is an active member of First United Methodist Church in Austin. She served as medical director for the City of Manor's COVID response team and helmed the Manor Vaccine Project in 2021. She is a founder and director of the Manor Wellness Alliance and directs its monthly Manor Free Clinic for folks with no health insurance. And Dr. Smith is committed to mentoring and supporting the next generation of doctors and is faculty at both the UT Dell and Texas A&M Round Rock Medical Schools. She is currently the chair of the Heart of Texas chapter of the Texas Academy of Family Physicians and currently serves on the TAFP Commission on the Health of the Public. That's impressive. And Dr. Smith, I'm just going to turn it over to you.
2 caveats. I am not here representing my employer. I usually introduce myself as a local family physician. And I am the immediate past chair of our local chapter of family physicians because we just had our election, but I get to stay on the board for another year to guide and help. So I created those bylaws when I had been the chair for 3 years in a row when no one would sign up. They say the vice president becomes when the vice chair becomes the chair and the chair becomes the immediate past chair, and you have continuity, and I focused on that, and I got someone to sign up for vice chair, and then a year later I was able to finally hand it over. I'm doing a second term now. I'm an educator turned physician. My biggest claim to fame locally is that I am the mother of Jeremy Smith, West Point grad, Special Forces veteran, and the founder of registertovote.org, Blue Squad, and something called Civitech that if you're interested in running for office is a way that people who can't fund their own campaign and afford a campaign manager can pay for software that will do those things for them based on how many voters they're trying to attract. So a small race is cheaper. I'm really proud of this kid, and usually if I go to any kind of progressive or liberal events, that's my entree. I'm Jeremy's mom. So, I've been asked to kind of focus on research cuts and rural medicine. One of the beautiful things I think, Dr. Mann, about family medicine is that you can do so many things with it. And the residency that I trained in many years ago, somewhere else, really pushed that, many hats. I tell my students, a family doctor is like a stem cell. Forgive my nerdiness. You can go to a community and then you can develop into what that community needs. If there's not a pediatrician, you can wear that hat. If there's not a geriatrician, you can wear that hat. If no one's delivering babies, you can do that. And I want to point out something that I think is interesting about our profession. Around the mid-1990s, insurance for delivering babies for family physicians in our state became prohibitively expensive. The malpractice coverage cost more than you could make unless you delivered babies all the time. So during that decade, most family physicians, by choice, because of economic necessity, quit delivering babies in the mid-90s. When did our maternal mortality crisis start, especially in rural areas? Around the year 2000. I don't think that's unrelated. The other thing about our profession that I want to put on the table, I realize that it can seem like we have a lot bigger fish to fry. Maybe we need to get people cancer treatment. Maybe we need to get people diabetes treatment. My daughter-in-law went to her family doctor for her checkup in May and was sent for a routine screening mammogram, her first ever, at the age of 39 because she would be turning 40 that year. 2-centimeter cancer on the left. We have now, as a family, gone through chemo and surgery. So far, it looks like we're going to have a successful result. I find 2 of those a year. I find a lung cancer every year in people who didn't know they had anything wrong. I have 4 patients with lung cancer who are still alive 4 and 5 years later because we found them early. We now have a test for that. If you're a smoker and didn't know that, or a former smoker, please ask your doctor. So primary care not only can treat hypertension, diabetes, step over, do pediatrics. I did over a decade in newborn care, hospital-based newborn care. I've done a lot of circumcisions. I never thought I would make a living getting up in the morning to do circumcisions. That is not something that was on my bingo card. But when parents wanted them, I would do them ethically and gently and kindly. And I want you to know something. In a decade of that, hundreds of procedures, I never ordered Tylenol once. That's not even a thing that is done. I never saw another doctor, pediatrician, or family doctor order Tylenol. For circumcision, our pain control is injectable and sugar water on a pacifier, and taking them right to mom to nurse or have a bottle afterward. I just wanted to put that out. I became a rural hospitalist around the year 2015 because I thought it was an important cause, and I did a 2-year stint in the Panhandle. I'm from Houston. It's a little different. I love the Panhandle. I love the Flatlanders. I love my farmers and my cowboys. And the smell of money in the morning, if you are from there, you know what I mean. It smells like a cattle ranch in the Panhandle. And I'll say, oh, it smells like manure. And they'll say, smells like money to me. I have given health talks at the nuclear factory in Amarillo. There is one. We are definitely on first strike list in Texas. But what I learned working rural hospitals is I would live in Amarillo and be sent to smaller communities where they have smaller hospitals because we wanted these hospitals to stay open. And we would I was the medical director, and I would hire other doctors who could keep the ICU open for a night if we couldn't get someone to the city. One night there was a blizzard. We couldn't fly, we couldn't helicopter. Amarillo's ICUs were both full. And they said, oh, we'll take him in an ambulance to Lubbock. It'll only take 2 or 3 hours. This man was 90 years old and neuroseptic. I said, he won't live that long. So, because we are trained in multiple types of care, I was able to open the ICU and keep him there overnight and keep him alive and run a sepsis protocol on someone with heart failure and actually use Levofed. Yeah. The next morning, I finally got him a bed in a critical care at Amarillo. And his 61-year-old son stepped out of the room and said, ma'am, I heard you just got him a bed. Please don't make us leave. I know what it's like in the city when the ICU is full, and we have never had care this good. Rural care can be excellent care, but you need a reason for doctors and nurses to go there and stay there. And if you don't pay them, that's not going to happen. A couple of things I learned during that time. One was about 1115 waivers. I am not a policy person, I'm a family doctor, and I did some liberal arts and psychology and education training before that. But this was really important for one of our communities. Moore County was doing an 1115 waiver. 1115 waivers, I have it pulled up for you so I don't mess it up. Vehicles states can use to test new or existing ways to deliver and pay for healthcare services in Medicaid, or CHIP, the Children's Health Insurance Program. This county had a wonderful nutritionist who was doing nutrition intervention, food. Aristotle said, let food be your medicine. With diabetic patients, those dollars were keeping that hospital open. That one Medicaid program. I did not know until I went here, because small hospitals have something called swing beds. What that means is, say your hospital is 24 beds, because 25 puts you in a different category, and they're not full. You can swing some of them into rehab, and your physical therapist can do the daily rehab. So we would have patients have a knee replacement, and then a day or two later, they were suddenly a rehab patient, and I only saw them once a week, and I had to teach the nurses not to come running to me for everything, because they were now a rehab patient. We had at the very end of the hall a hospice room. This was a small building. It was like, the orthopedic surgeon showed me one day, nursery, operating room, med-surg, nursing home, and out that door when they pass away. He said, you can live your whole life in this town on one hall. But they were doing good work for this community. I didn't know that Medicaid is the only thing that pays for nursing homes. Most people don't buy long-term care insurance. By the time you know about it, it's too expensive. You need to buy it when you're like 20, right? Medicare pays for maybe 100 days a year of skilled nursing, right? That's what, 3 months, a little over? And the rest of it you have to pay. You have to pay everything you had that you were going to leave to your children. This is the reason that the middle class and the working class doesn't leave wealth to their children nowadays. You get to that stage, and Medicaid doesn't pick up the tab until you're indigent. Once you've spent down everything, then Medicaid pays for the nursing home. Well, guess what we're paying? Our current ratio of nurse to patient in a nursing home is 20 to 1. These are people who get medication multiple times a day, need help to bathe, help to go to the bathroom, and they need attention and relationship. The nursing ratio is awful. It chews our nurses up, and CNAs end up doing a lot of the work as extenders of these RNs, but we need to do better for our nurses, and we need to do better for our patients. We need more money in Medicaid, not less. And I think what's driving all of this is kind of a perverse, racist idea that Medicaid is for black welfare moms who do this on purpose and have a lot of children to live off the state. No one does this on purpose. No matter how much brown is in their skin, no one wants to be on this. But my question is always, if we really are a country that values families, motherhood, and children, why not? Why wouldn't we fund that, and why wouldn't we fund it well? I was telling my daughter-in-law this morning, it appears to me that we are not a nation that values children. We say we do emotionally, but if you look at our actions, Wendy Davis has a program called Words, Deeds, Not Words. Look at what people do, not what they say. We don't fund schools. We don't fund CHIP. We don't fund Medicaid. Enough about that. 1 million people losing coverage with Medicaid. We know that every time 400 people lose healthcare coverage, a person dies. That statistic is held up over time. We are literally killing people with these policies. Women's health. One of the recommendations of the first commission on maternal mortality in Texas was, please expand Medicaid. We have rising mortality again now because of badly written law. Whether someone's pro or anti-abortion, these laws are badly written. It's It's the same procedure, whether you're having a miscarriage and need your life saved or having an abortion. It gets tricky. But I would like to have liberty in the exam room between a doctor, a woman, if she wants influence from her family, her faith leaders, her spouse, her partner. That's a real decision. Trying to impose one from on high is a little nuts. We don't have research in women's health. Not enough. There is no parity in health. I don't know if you know this. Until about 1980 or so, all research in medicine was done in men because no one wanted the liability of hurting a pregnancy. And we assumed that women's bodies were just like men's. I was sitting in a freshman medical school biochemistry class when this scruffy professor with a giant gray bushy beard, you know the kind, the biology and the psych professors, they always look the same in college. Yeah, they look like that in med school too. And he was talking to us about the liver and the liver processing drugs, and he said, women have different enzymes in the liver than men. And he kept going, and I said, wait a minute. My hand goes up, 200 people look at me like, Karen, don't ask another question. And I said, did you just say that men and women have different enzymes for processing medication in our livers? By the way, this is why women are harmed by alcohol sooner too, not muscle mass. He said, yes. And I said, do we know how women metabolize our drugs? And he said, everybody? Everybody? Nope. Would you ask that again, Karen? I ask it again. Do we know how women's bodies metabolize our drugs? He let the silence hang, and I watched a clock in the room. We used to have those, right? 2 minutes. And then he shrugged and turned around and started writing the next problem on the board. And the message I got loud and clear, I was a former educator of the curriculum committee, and I understood there's some politics behind what certain people can say in class and not, based on whether you have the Nobel Prize or the National Academy of Science. There's politics in everything, right? That question bothers me still today, and I teach my students, if a woman tells you that drug doesn't work for me, listen. Don't get me started on that one. The complexity of coding. Waste, fraud, and abuse are based on coding. We are now using corporate measures and corporate minutiae to manage medicine and education, and they are poor fits. I didn't learn accounting or anything like it in undergrad or med school, but if I put a code that's too simple, even if it's true and something's medically indicated, it will get denied. Automatic denials are now a business practice. And I don't know about Dr. Mann, actually I do, but I'm working from 7:30 in the morning till 7:30 at night to do my 8 hours of exam room time. I don't know when I'm supposed to call all these insurance companies and talk to them for 2 hours, right? Sometimes I get the fax that says this was due yesterday. And if you don't have it by yesterday, you'll be denied. And I'm like, well, okay. That part is really hard. The last thing I'm going to say very briefly, touching on research, there is a great book. If you have a pencil, write this down. It is by Walter Isaacson, and it's the biography. Let me get it for you. I'm going to get you the biography of the woman, Jennifer Dula, that did some of the research on CRISPR, on RNA. Let me get you this. Walter Isaacson wrote it, and he was the editor at Time at one point. And I'm going to get you the name because it's a great book and it's really well written. I will get it in a minute, so I won't take. Jennifer Doudna, D-O-U-D-N-A.
Say it again.
D-O-U-D-N-A. She's a microbiologist, geneticist, and biochemist. And the biography, she's the subject, it's written by Walter Isaacson. I will get you the title. Last thing, I believe the amount, you can help me out, of the Affordable Care Act set aside and left on the table for Texas for Medicaid expansion was $900 million originally,
Originally, yeah, that sounds right. It shifts every year.
Yeah. That has been sitting on that table ever since. Free money that we are not using to fund healthcare. I think the most important thing anything of us can do right now is small and strategic. There is a state, we live in it, that is trying to gerrymander districts to send more representatives that don't support healthcare for their neighbors to Washington. There is a state that is trying to fight back to send more representatives that will. Sending money right now to California to help with the Proposition 50 campaign might be the most strategic thing any of us can do. $5, $10, I'm not involved with that. Looking big picture, I think it's important. That's all.
Next, I'd like to introduce Dr. Christine Mann. Dr. Mann is a board-certified family medicine physician with 30 years' experience working in our healthcare system. She has worked as a clinician and in an administrative capacity. Dr. Mann has been involved in political and community activism for the past 2 decades. She has volunteered her time in a variety of capacities, including working as a CASA volunteer, yay, sitting on the Williamson County Child Welfare Board, and serving as a volunteer deputy voter registrar. Dr. Mann ran for United States Congress, again, yay, in 2018 and 2020, advocating for a single-payer universal healthcare system that would cover every American throughout their lifetime. So, Dr. Mann, your stage now.
I didn't test this before. I guess it's not working. I guess it doesn't. And I'm sorry, I don't know your name that's doing the AV. My thing for advancing the slide is not working, so I'm going to have you advance the slides for me. Okay. So I thank you all for being here. This is very heartening. I periodically do this kind of thing, and every once in a while, like 2 people show up, and it's really great to see so many people here. And there were 2 topics that they wanted me to have. One is attack on vaccines. It doesn't dovetail with what we've already talked about, but we'll go through these slides first because that's what I have up here first. And then I want to get to some of the topic that will dovetail with what's already been talked about. Next slide, please. So I want to give you a little bit of a personal background on this. I was a vaccine skeptic in my prior life. I had my first child when I was 21. It was in the 80s, and it was around the time that the Andrew Wakefield study came out, throwing concern out there for vaccines. And I did my research. I read some books, and I was concerned. And so I really have had the experience of relating to people who are vaccine skeptics still today. I don't agree with that at all, and we'll talk about why. But I feel like because of that background, I'm kind of uniquely able to have that conversation with patients because I came from where they are coming from now. And sometimes when I was in primary practice, that worked really, really well. I was able to convince people to go ahead and vaccinate their kids because I was able to relate to them on that personal level about where I came from. So I wanted to give that full disclosure as we go through this conversation. That was before I went to medical school, clearly. So here we are now. Just initially some statistics on healthcare, or on vaccines. The World Health Organization estimates that vaccines have saved at least 154 million lives in the past 50 years. That's remarkable. It has improved in 154 million.
Not 150 years.
In the past 50 years, yes. And it's billed as the most important medical advance, saved more people than any other medical advance we've made ever. So this is a really important topic for us to be talking about. The CDC, which used to be super reliable, not so sure anymore, estimates that routine childhood vaccine has prevented at least 1.3 million deaths in the United States in the past 30 years, and vaccines have nearly eradicated quite a few different diseases. I put on there purposely the information about HPV because this one really gets to me when people are not vaccinating their teens for HPV, because the rates of cervical cancer are plummeting since the HPV vaccine started being given. So really important that we include some of these statistics when we are talking to people. Next slide, please. So in my prior life and when I'm talking to patients, these are the three main myths that I have encountered in terms of why people are vaccine hesitant. 1, vaccines overwhelm the immune system. 2, they contain dangerous ingredients. And 3, they don't undergo proper placebo-controlled studies. So we'll break those down real quickly. Next slide. If you took all of the antigens are the things that stimulate your immune system to create an antibody response, and you gave them all of those antigens from all of the vaccines kids get, it's fewer than 200 antigens. So if you gave them all on the same day, all in one thing, there would be less than 200 antigens that your immune system would have to respond to. Contrast that to, on average, people are exposed to tens of thousands of antigens every single day. You're breathing antigens right now. You're touching antigens when you touch the chair next to you. I'm touching them on my microphone. We eat them in our food. So the idea that this tiny amount of antigens that we give children is going to overwhelm our immune system is just, it doesn't make any sense. If your immune system was going to get overwhelmed by exposure to antigens, it would get overwhelmed by your daily life, everything you do every day. And the beauty to me of vaccination is that we figured out how to take a tiny, tiny, tiny portion of that infective agent and teach our immune system to respond and protect us without ever getting sick from it. You build immunity when you get sick, but this is a way to do it without getting sick. Next slide, please. So dangerous ingredients. The one everyone talks about is mercury. There is a difference between the mercury component that, right? Mercury that it was in some vaccines and the kind of mercury that is actually dangerous for you.
And Freddie. I'm sorry, and Freddie Mercury.
Yes. So methyl mercury is the form that's dangerous. That's what's in fish. When we tell pregnant women don't eat fish, it's methyl mercury that we're worried about. It accumulates through the food chain, and so by the time you eat that fish, you've gotten the mercury from all the organisms all the way along the food chain. The type that was in thimerosal, which is a preservative in vaccines, is ethyl mercury. It doesn't accumulate, it's rapidly removed from your body, and there are no known ill health effects. Now the kicker is, there hasn't been thimerosal in vaccines since, what did I write down, 2001? Yeah, they took it out. So for the past 25 years, no one has even gotten any thimerosal, and people are still yelling and screaming about mercury in vaccines. It makes no sense. Many of the vaccines never even had thimerosal in it, never. And so logically, I don't know why this talking point is still out there with vaccine skeptics, because it's just not applicable at all. Now, my daughter was born in 1986. There was still ethyl mercury, thimerosal, in those vaccines, but again, there was no reason for me to be skeptical of that at the time. But that was definitely a huge talking point when my daughter was small and I was making that decision to vaccinate her. The next ingredient, next slide please, is aluminum. People worry about aluminum in vaccines, but aluminum is there to help, it's called an adjuvant. It helps your body form an immune response. So it's a very necessary part of that vaccine. It's the most common metal found in nature. You eat it, you drink it, it's everywhere. And so, you know, I put this stat up there that I thought was interesting. Babies ingest more aluminum from breast milk or formula than they do from vaccines. So again, if you have a cousin, a niece, a nephew, daughter-in-law who is expressing skepticism about vaccinating your loved child, these are some of the things you can talk to them
Did
about.
you say that aluminum is natural?
Yes, aluminum is completely natural. Yep. And the third ingredient that people have always brought up to me is formaldehyde. Formaldehyde, your body makes it. So there's not a concern there. It's in plenty of foods. I think I read a stat one time that a banana has more formaldehyde in it than your vaccines. So I hope that some of these like myth busting can be of use to you guys if you have people in your life who are talking about them. And the risk here isn't just to the people who aren't vaccinating. We've seen these huge measles outbreaks, for example, and yeah, most of the people that got measles during these outbreaks were not vaccinated, but there's a portion that were, because vaccines don't give 100% immunity to 100% of the people. That's just part of the deal. There's absolutely nothing in healthcare that I can guarantee you will help 100% of the people 100% of the time. That thing does not exist. And the vaccines are no different. So it affects us too, and immunity can wear off. Vulnerable people become more vulnerable as they get older. Young children can't get vaccinated. So this is a topic even for those of us who are fully vaccinated and fully pro-vaccination to try and understand if you ever have these conversations. Next slide. The next thing, and this one is really loud right now, that vaccines were never placebo controlled. Like I'm hearing this, reading this, seeing it on social media all the time, and it's simply not true. So part of the reason this talking point has come up is because of how vaccine development and like how our vaccine schedules have evolved over time, right? So every original vaccine was placebo controlled, every single one. Going back to the 60s, measles was placebo controlled in the 60s. But then what happened was we found out that each of these components separately were completely safe and effective. So in order to reduce the number of jabs, the number of shots, we combine them. It makes it easier, simpler. We have better compliance. We have more people get fully vaccinated if we put them together. Well, you can't placebo control a combo against saline because you already know that those components work, and that is unethical in medical studies. You can't give people a saline shot when you know that what you're giving in the trial arm is effective and safe. And so all you're doing in those later studies is you're comparing the combo to the individual components in terms of effectiveness. Meaning, we know each one, measles, mumps, rubella, for example, they're all individually effective. Will giving it in a combo be as effective together as the individual components? So you don't give saline against that, you give the individual components, and it turns out they're just as effective. So that is just a huge myth that just persists all the time. And it is crazy how many people say that and think that. So that's all the stuff I have on risk of, or on vaccination. We can talk about questions and so forth in a minute, but I want to do the next part of my presentation, next slide, which kind of more dovetails with what our other two panelists were talking about, which is how will medical and mental health practices change. Next slide, please. No, you can go back. That was there on purpose. Like, we don't fully understand and we don't know exactly how things are going to change. What I did in this presentation is put out some estimates, some numbers, some things that the budget crunchers are looking at and thinking about. And then, I'm sorry again, I don't remember your name. There is, are you using my computer right now? No, okay. So, the reason I asked is because the thing that I couldn't get into the slide presentation, because I am terrible with tech, was a photo. No, it's something I have personally on my computer. It is a photo it's a screenshot of something that is going on in my clinic. I work for HCA, one of the largest healthcare companies in the United States. And I took a picture of the TV monitor in the patient room because I didn't even know we were doing this, and I just saw it. It is a photograph with a QR code encouraging people to call their Congress people and talk about the concerns with the changes that are coming in healthcare. I have never seen a healthcare entity do something like that before. They started putting it up for us, like it was on our internal information. Now it's in patient rooms. And when a healthcare entity as big as HCA is encouraging people to call their Congress people, they're worried. I don't think there's anything stronger that I can tell you or show you than the fact that a healthcare entity, one of the largest in the country, is telling patients to call their Congress people and giving them a QR code to make it quick and easy to do. That blows my mind that we're at that point.
Yeah.
Because healthcare entities stay out of politics on that level. They're in politics with their little money, like they give money all the time, but to trickle it down to patients is mind-blowing to me. So if any of you guys are interested afterwards, I can show you that picture. But it circulates in our rooms in our clinic. Next slide, please. So, starting at baseline, as of 2024, more than 27 million people had no healthcare insurance coverage nationally. So I'm talking nationally right now, just Texas. That equates to about 8.2% of the population already, almost 10%. Think about that, that's crazy. And the estimate right now from the budget crunchers is that 16 to 17 million people will lose their coverage by 2034. So it's going to be a slow bleed, but that's where we're headed. 11.8 will lose Medicaid by 2034, and 4 to 5 million people who get their insurance through the Affordable Care Act will lose their coverage. And that has to do with all of the policy issues that Lynn was talking about, the way that they are creating these policies to reduce subsidies on the ACA and to do these tweaks to Medicare. And I'm going to talk about how this is going to affect Medicare in a second. She brought up, like with Medicaid and changing eligibility rules, that's where a lot of that is going to come from. And there's a big myth in the general public that Medicaid only covers people who are low income, which in Texas, that's not even a thing. But it's the largest provider of, as someone mentioned, nursing home coverage for seniors. Seniors are going to be horribly impacted by the cuts to Medicaid. Next slide. There is discussion and conflicts in the idea about how people with private health insurance are going to be changed, how their coverage is going to change. But the overall theme is that at a minimum, out-of-pocket expenses are most likely to go up. I'll talk about why that is in a minute. Same with Medicare, and especially Medicare Advantage programs, because again, those are private entities that are that are providing coverage to Medicare populations. And here's where I'm talking about how it can affect other things. It's a domino effect. When Medicare sets its rates for reimbursement to doctors, they'll send us contracts as private doctors. And basically you sign there's no negotiating, you just sign or you don't. And it will say, we will pay you 110% of what the Medicare reimbursement rate is. And that's how you know what your contract is and what your reimbursement rate is with an insurance company. when Medicare drops what they pay, it affects private insurance too, because now if Medicare pays 50% less, which is not going to happen, but it's too big of a number, but just for the sake of argument, if they drop it 50%, private insurance contracts also, they're going to follow suit. That's correct. So you might think you're protected with your employer-provided healthcare coverage, but those plans follow what Medicare does. Another thing that Lynn was bringing up was about the pre-existing conditions done by AI. If that pilot is successful, I can guarantee you private insurance companies are going to follow that model, and it's going to affect people with private insurance too. That's just the way the healthcare system works. And I will tell you, Jan mentioned that one of the things I've done in my life was run for Congress twice. And there's a reason I'm bringing this up right now. I have advocated for a national health plan, single payer, Medicare for all, for a couple of decades. It was pre my running for Congress. And I was sure that there was a huge groundswell appetite for that when I ran for Congress. And when I would have conversations with people, and some of you guys know which primary I ran in, so the people who were in my primary pushed back. And they said, we don't want to do that. They said, I don't want to lose my personal insurance plan. So I'm not in favor of that. Multiple of the other candidates who were with me in my primary, I would have conversations with them. No, we don't agree with that. We don't want that. We're not going to do that. So I say this to you because Lynn brought up the point about being a healthcare voter. It's not just enough to be a healthcare voter. You also have to be talking to friends and neighbors and family members about these issues, because you might be surprised that people you agree with ideologically don't support something like this. It was the shock of my life. It was devastating. Anyway, moving on. Hold on, I lost my place on my slides here. Okay, which one do we have up here?
The domino effect.
The domino effect, okay. You can go to the next slide. So this is just about how these effects are going to trickle down. Who's going to be the most affected? Seniors, people living with disabilities, people with chronic conditions, low-income adults, children. I think it's 39% of children are covered by Medicaid. So if those cuts come down to Medicaid, that's going to affect a lot of people. If more people get kicked off their regular insurance, there's going to be more people trying to get Medicaid. Medicaid is drastically underfunded. There's all these moving parts that together spell a problem. Mental health. People already have trouble finding mental health providers. Already 25% of people seeking mental health coverage can't find it. And that is a thing that's going to definitely get worse with the cuts. We do not take mental health coverage seriously. We do not have it on par and on parity with general health coverage, and it's already a challenge. So, man, I'm a Debbie Downer tonight. I'm sorry. I'm worried. I really got more worried when I saw healthcare at risk. Yes, exactly. Seeing my company put those slides in the rooms really kind of galvanized it for me. So. That's the end of my slides, the end of my presentation. I'm not sure if either of the other panelists have more things that they wanted to put out there. If not, then we would be more than happy to have questions.
I think we need to move to audience questions now.
Okay. One comment. Insured cost rise when people lose coverage for many reasons, but two big ones. One is something called the EMTALA law. When people don't have coverage, they end up getting their care at the emergency room, which is incredibly expensive. Hospitals have to find a way to cover that cost, so they have to raise rates for others, or they go out of business, especially rural hospitals. And number two, you will find that your hospital district tax costs go up for that same reason. And if anyone is interested in starting a free clinic to be a safety net under the safety nets, we are creating a toolkit, and I'd be happy to talk to you because I think we're going to need them in the near future, hopefully not forever.
And I want to say that's amazing and wonderful, but it signifies that we're not doing things right. It's it. Anytime I see someone paying off someone's school lunch debt, that's a policy failure.
That's right.
Anytime we need more safety net health entities, that's a policy failure.
That's right.
We're failing our fellow citizens.
The book, she's exactly right, but we're still gonna do it. The book is called Code Breaker.
Okay, thank you very much. Okay. We have a microphone right here in the middle. If you have a question, please come up to the microphone. Yes, ma'am.
Hi there, thanks for being here today. I just got my open enrollment information for private insurance, and my deductible is going up from $400 a year to $3,400 a year, so $3,000 increase. And I'm wondering, is this just corporate greed, or is this because of what's happening with the other cuts?
Yeah, it's what's happening because of the other cuts. So issuers right now are struggling to anticipate reductions in revenue in their own companies and trying to find ways to offset those to ensure essentially a sicker population. So because we will have between 0.75 and 1.5 million fewer people insured in Texas, the healthcare industry has to absorb the costs of insuring people who, in spite of the fact that insurance will cost more, will remain insured regardless. And that tends to be a sicker population than the general population who would get into health insurance plans if they cost $5 or $0 per month. But because the opportunities for people to be enrolled for $0 per month have decreased to the extent that we're anticipating that those millions of people will just drop coverage, then the people who will retain coverage will be sicker, the risk pool increases, and so insurance companies have to negotiate the numbers between co-pays, deductibles, and out-of-pocket maximums to try to offset those costs themselves. That said, insurance companies also make a lot of money. They could anticipate a deficit year if that were possible, but because many insurance companies are privately owned, they wouldn't be performing their fiduciary responsibility to stakeholders, and so they would prioritize then the wellness of stakeholders over the wellness of insured people, which is devastating. And if you want, there are healthcare navigator teams around the state of Texas who could help you see what your other options are. There might be a plan that has a lower deductible that you could get into that covers your doctors also. If you live in Williamson County, I think there will be like over 90 plans available next year at bronze and silver and gold levels. So in some cases for some people, there are bronze plans that have $0 deductibles available. Not quite sure if that'll happen next year. We don't have the 2026 plan information yet. But I can connect you with those folks if you'd like.
I want to dovetail on something she brought up, which is the fiduciary duty of insurance companies. That's the problem in a nutshell. Like, it's the law. They have to protect their shareholders. They have to. That's the whole reason for-profit healthcare is a problem.
Right.
Because they are required to do that. They have to protect their shareholders. So when you ask me if we can just regulate our way out of the issues with for-profit healthcare, I'm going to always tell you no. There should never be profit in healthcare, in my opinion.
But it could help.
Hi, thank you all for being here. I knew you as Dr. Eady. Yes. And then you tagged me on the end. I voted for you.
Thank you.
Just saying. I'm really interested to know, and I think you might have just answered this, who's benefiting from all this? Because to me, this all sounded today like everybody's losing. Whether you're fully insured or completely uninsured, everybody is losing. That we are all expendable commodities. I'm sorry, I'm important.
Yeah.
I'm the senior citizen in my family. And I don't like feeling like a piece of thrown away meat. And as I age, benefiting. So who is benefiting?
Billionaires. Billionaires are benefiting. This pay-go mechanism that we're discussing states that if we reduce these tax rates, we have to find cuts elsewhere. That's where it's starting, is with these massive, massive tax cuts, especially for the wealthy. That's it. Trump is paying his donors, my friend.
Yeah, no, you're absolutely right. And also, like, functionally, like, in the healthcare system, over the course of the last 60 years, we've seen these, like, I mean, fill in the blank, right? So many third-party administrators who exist to streamline or supplement or
Take a piece of the healthcare dollar.
Yeah, so like we have the insurance company who covers the covered person and the provider, and then there's also a pharmacy benefits manager or a third-party administrator, and so like these third-party administrators will suck so many dollars out of our healthcare system that are largely unnecessary if we had, again, like a streamlined system where there was clarity and transparency among payments between whether it was a single payer or multiple payers, different insurance companies that were subsidized by the federal government or state governments in some way.
To put that in English, in case it was a little vocabulary for you, a pharmacy benefit manager is a corporation an insurance company pays to go out and negotiate the best drug prices for that insurance company and their members. They buy in bulk. They say, we have this many covered lives, this many million people who will use your drug if you will give us a discount. And now there's a company like that for x-rays and imaging, right?
I mean, yeah, I'm down the line. These are parts of the reason that healthcare is so expensive. And then, I mean, also there's just the reality that, you know, Medicaid pays pennies on the dollar, Medicare pays pennies on the dollar when you get into hospitals, and that transfers the responsibility for payment onto private insurance companies. So really, like, the whole healthcare delivery system right now is overcomplicated in ways that allow institutions, businesses to find their ways into them to siphon money out. And because of those things, we have, I mean, on various ends, you have struggling rural hospitals that will close because of these cuts, and then you also have other privately owned for-profit hospitals that will continue to make money, depending on what people are going to them and what types of coverage they have, or if they have self-pay. So
when I was in private practice in 2012 in Fort Worth, I read an article that made me so angry I've never forgotten it. That year, the CEO of Aetna was angry because his bonus was only $70 million. And all the other insurance company CEOs had bonuses that were 3 figures in the millions, over 100 million, and he felt like he was being ripped off. So this, again, imposition of corporate culture onto healthcare, I think people instinctively know that healthcare isn't business. It's certainly not corporate. It doesn't fit. For enterprise, sure, a small doctor shop, fine, but this is not working.
Do we have any more questions?
Yes.
Okay.
If I could ask you, coming from the perspective, and by the way, thank you all for being here, coming from the perspective of someone who took care of my mom for years while I worked full time, and unfortunately had to make the decision to put her in a nursing home at some point. And so, can you paint a picture for us from a timing perspective, from a loss of benefits, like what someone could expect to see if their loved one is in a nursing home and all these cuts happen, and eventually they might be faced with having to bring that loved one back home again. And so, how long might that take, and what might the major steps be before people start seeing these really serious effects?
So there's a bunch of ifs on that. If you noticed in my presentation, I talked about what's going to happen through 2034. So it's a 9-year time frame. So it depends on how the legislation gets adjusted, changed, and enacted. And we've had some legislation where, like, it was immediate and the cuts were immediate. I don't know when all of the cuts kick in. Do you know?
I mean, I just nodded like, yeah, I know. But the reality is, like, so the federal cuts stand as they stand right now. And then the Texas legislature will meet during its 90th session in 2027. And that's the time when Texas lawmakers will decide whether they'll pull from the supplemental budget to continue funding our 1115 waivers and others kind of like supplemental Medicaid programs like some of the nursing home payments, or whether they'll pull from the rainy day fund. The governor has been seriously resistant on pulling from the rainy day fund for the last number of sessions, even though we're basically at the cap of the rainy day fund right now. So there's federal advocacy that we can all do together, and there's also state advocacy that we can do together. And that means like making sure that our lawmakers, especially some of our freshman lawmakers who don't know how Medicaid financing works, to get into their offices and say, we've had these trillions of dollars of cuts from the federal government, we have to shore them up from the state level, right? And if they don't, then we would see those cuts usually, in the past, within 3 to 5 years after the passing of the federal legislation. So we'd be looking at 2027 to 2028 to 2029.
Okay, thank you. We have 2 more questions, and that is it.
Just real briefly,
Okay.
the first thing you would see is worse care while the nursing home struggles to do more with less. Fewer nurses, worse food, cheaper medicines, less staff, not redecorating, you get the idea.
Yeah. Okay, thank you.
2 more questions, and that's just what we have time for. Okay.
Hi, thank you for being here. I might have missed the answer to my question. My husband is on traditional Medicare, health insurance that he pays for. On the other hand, my employer pays for my insurance, but I am on the Medicare Advantage plan. And what should I be concerned about?
It's great until
Because,
you need
because
something.
currently my employer pays my insurance. The state of Texas reimburses the employer. I work for Austin Community College.
A Medicare Advantage plan is awesome at the beginning if you don't need much. There's vision, there's dental, your medicines, you don't have to worry about the donut hole. As soon as you have cancer, it's terrible and doesn't tend to pay for what you need, and most doctors are opposed to them for that reason. Can you help with that?
Yeah, I was actually gonna boot it over to Lynn
Yeah.
because, there's kind of some policy pieces to
There's some
this.
policy pieces to this.
Yeah, I think honestly the best thing for you to do would be to reach out to our benefits enrollment counselors at the local area agencies on aging. These are the experts who know about the Medicare, the pitfalls and the benefits to some of the local Medicare Advantage plans. What Dr. Smith has said is accurate. People tend to find better benefits in traditional Medicare if they have higher healthcare needs. Yeah, in the long term, right? And you can only change Medicare Advantage and regular Medicare now during the enrollment period, which of course is coming up. So I would say if folks have a trusted resource in Medicare to talk with them about their specific healthcare needs, and if you don't have a trusted resource, the local area agencies on aging, and these are around the entire country. These are offices that are funded specifically to work with folks who are either newly enrolling or re-enrolling in Medicare plans during the enrollment periods. So I realize that's not a specific answer to your question, but the specific answer to your question is going to depend so much on the needs of you and your spouse over time.
Right.
Yeah.
So I have the option of going on the website and clicking on a button and changing to Blue Cross Blue Shield, but then I'm stuck in the copay.
Sure.
Which,
The best thing that most people recommend generally is traditional Medicare with a supplement that covers vision, dental, and keeps you out of the donut hole. The donut hole's horrific. I have patients who fall into it who've worked their whole lives and their social security income can't cover their medicines. I have to put them on charity programs from drug manufacturers but once they're on the charity program, they're never gonna hit it. So, their drugs get paid for until April, and then we have to go looking for free programs for people who worked their whole lives and paid into the system. So the donut hole's real. That's the big disadvantage to traditional Medicare, other than not covering your vision and dental and
okay.
hearing.
I have one more question, if I can ask. I have a family member, a cousin, who lives off of her inheritance. When that money is exhausted, is Medicaid gonna be there for her? Because or else she'll
That's
be
right.
homeless.
It depends, yeah. If she's living off of her inheritance, then she's not paying into tax system, or maybe she has, like, if it- depending on whether or not the inheritance comes from a trust or,
Recently, we had her enroll in, insurance, so she'd have
in Obamacare, or in
no,
a different, okay,
United Healthcare, I think. is what
Okay.
it is.
yeah.
It's the AARP. United.
Oh, okay, she's retired then, or of retirement age?
She's 72.
Okay, gotcha. Yeah, I mean, the availability of Medicare to this
Before
person.
that, she wasn't really spending that much money, so the couple of bucks that, she was paying, just didn't,
Yeah,
we figured better do it now before it's too late.
yeah. I hope I'm answering your question right. Medicare availability is based on people's work histories in the United States. So, if she's been paying taxes on that inheritance for 40 quarters, then Medicare would probably be open to her. But if she hasn't, then she wouldn't have the work history requisite to be on
She hasn't
Medicare.
worked since she's 55, so.
Okay. But she worked before then, or no?
The question was
She,
about-
she hasn't worked since she's 55. She had very low paying.
Okay. Well, she was paying taxes for 10 years before then Medicare would still be available to her. And then Medicaid, if she did have a low income, would help her pay for some of the costs of Medicare.
Well, once her funds are exhausted, she'll be penniless,
Mhm.
That's what
you know.
And that's when Medicaid would pay for a nursing home. She'll have to pay cash for one if she ever needs one until then, if that's what you're referencing. Medicaid pays for the nursing home, Medicare pays for the health care.
Okay, listen, I bet Lynn would be happy to talk to you after we finish here, give you specific information. One more question.
The question, sorry, thank you all for being here. Question I had is regarding the CMS pilot programs for those who are Medicare eligible. Have they said what they're trying to do? Because I've been reading Republican white pages for well over a decade and lost well over 250 pounds because I'm like, oh my God, this is coming. So what are they trying to do? Because I've actually worked hard to take care of myself or undo what I had done actually. So what are they planning? Do you have any idea?
They're trying to kill us all.
Yeah, I know that part. The question is how soon, how many?
Which, I'm sorry, there's so much that comes out of CMS that I'm wondering if you could specify which studies
What
or
are they
pilot
gonna
programs
try
are
to
talking.
deny, cut off, or play games with? Do you have any idea? I don't.
Are you talking about the AI program, the
Yeah.
pilot program?
Yeah.
I don't know what the first pieces of that are gonna be, do you? Like what things they're going to,
Well, they're going to start making, requiring pre-approval for,
Well, that's already happening.
well, it's not happening that much in traditional Medicare. Historically, it is not. There's been very little pre-approval.
I'm in the state program that's Advantage, so
Well,
there I have to do
Medicare
prior
Advantage is a
approval.
whole different thing, that's
Okay.
through private insurers, so, we're talking about two different things, but I think, a lot of people think that this pilot program is just a backdoor way to privatize Medicare. So if you wanna know what's gonna happen, what they want to do, that's what they want to do, so.
A
Yeah.
seamless pilot program, I just Googled it, is a transitional piece that a corporation uses to make a transition easier. So I don't know anything about seamless pilot programs for Medicare. The other two might, but I'm not aware of that particular feature.
Okay. Because right now, the state system, you can transition without having to do a QLE from the Advantage to the other, and you don't have to play the games that you do in certain states, like only on a qualifying life event.
Yeah.
So far.
I'm unfamiliar with that.
Yeah.
Generally, the enrollment periods are pretty strict for
And I've been
Medicare.
in two systems, North Carolina and Texas.
Okay,
I've been
gotcha.
I
Yeah.
left North Carolina because they gave me 5 different answers for one question.
Well, and I think you're really getting to like something that we've all talked about on this panel here today, and I think that probably everybody in this room has experienced, which is just like, again, like the over complexity of our healthcare systems, and like Jan just said right now, the trend towards privatizing, right? And we've seen this across industries and across sectors, but the reality is that like to transfer public money to private interest or to private entity is the goal. And then also to increase profit margins by making it less expensive to cover the rest of us for our healthcare. Right? The only solution to this is like truly a nationalized healthcare program. that covers people across the board, regardless of age, regardless of condition, right? And that stabilizes these healthcare costs for people across the board. So, there is good reason for some prior authorization, but like, not for a dermatological check, right? Like, we all need that, so there's no reason to go get a referral to go see a dermatologist once a year. So, but these are the common sense solutions that we can all advocate for together. And I realize that's just like such a general answer to your question, but like, the answer to the problem is a national healthcare program, and that's gonna take a
And
lot
you're
of money.
talking to the long since.
Yeah, I understand, yeah.
But
Thank you
not
so
one
much, yeah.
designed by this Congress.
Right.
Okay, thank you very much. Now, Michael West and he's walking up here. I'd like to thank our panel. Y'all have just been wonderful. Thank you so much. I told you were gonna get a lot of information today, and I was right. So, use what you can. This is not over. This is so.
And none of us are attorneys.
Thank you, Jan. Thanks to all of you for coming out. Thanks to our great panel. I know we all better get wise to wiser, because it's the first step on privatization. And just a quick note, we have some great information out on the advocacy table. Some of it brought from some of our great panelists here. And so please stop by. In particular, if you would like to sign letters to Ted Cruz, John Cornyn, and the Congress jerk of your precinct, of your district, or any Congress jerk in the GOP party, to tell them to stop the Trump shutdown. We got all that info out there for you to take with it. Also, in November, you guys are going to be voting on 17 constitutional amendments, and we've got a list of them out there as well that have the for and against, blah, blah, blah. I think the fors and against were put in place by Travis County Democratic Party. So you may or may not agree with all of them, but they're a good starting place, and be sure and vote in November. Thank you.